Good morning, everyone. Today we have our, I call it the goodie box. These are things that you're going to see out in patients' homes. It's not in any book anywhere. So that's why I said just go ahead and put your books away for now. Let's just talk about certain things that you may run across in patients' homes. Several different things. We'll start with the pill box. When we're in patients' homes, all the medications they take consistently must be in the pill box. You'll notice Sunday through Saturday is lined up. The most important thing is the actual box itself. You have morning, noon, evening, and bedtime. And what I like to tell people is breakfast, lunch, dinner, bedtime. So if a patient eats at 9, 1, 5, and 9, their bedtime snack, then you want to give them the pills that are in this box at this time. The patient should be able to, you hand them the box, they should be able to take the pill out of the box and then put the pill in their own mouth. Legally, you're not allowed to take the pill out of a bottle and put it in here because that's called dispensing, and the pharmacist is the only one that can do that, or registered nurse or physician. And then you're not allowed to take the pill out of the box and put it directly in the patient's mouth because that's called administration. And only LPNs and RNs are allowed to administer medications in the state of Pennsylvania. They are looking at changing that. Some of those types of laws, they have already done so in some nursing homes where a home health aide, CNA, they go to a class on medication administration that's taught by a registered nurse, and then they're able to do that in a nursing home. But in the home, this is the law that we have to follow in the home. Make sure you look at the medication profile sheet. If it says at 9 a.m. there's 4 pills, and you open this box and there's only 3, or there's 5, I would question that. I would call the office, get a hold of someone to find out why there's a difference. If you come in on Monday and Sunday night, the pills are still in there, that's a problem. They should have been taken. The pill shouldn't be in the box on Monday morning for Sunday night. Unless, for some instance, someone went there Sunday night and filled the pill box up whole. That's the only time pills would be there from the day before. Okay? Next thing I want to show you is Proderm spray. It's for stage 1 to stage 2 pressure ulcers. Stage 1 is when it's red for longer than 10 minutes. Stage 2 is when the top layer of skin's missing, the epidermis, and the dermis is exposed. That's the pink tissue underneath. This is used to increase circulation to the area. Proderm spray has to be ordered by the doctor. It's not something that's sold over the counter. It takes the blood vessels. Say you had a red area on your hip. You shake the can, hold it about 5-6 inches away, you spray it on there, then you let it dry. It takes the blood vessels and it opens them, it dilates them. So therefore, when you open a blood vessel, when you dilate it, more blood goes through it. And if you get more blood through it, you get more oxygen. And the reason the tissue was dying is because of lack of oxygen. So to get more oxygen to it, they spray this on, it opens them up, gets more blood, gets more oxygen. It'll allow it to heal. It works a lot, but you still have to find out what was causing the pressure and eliminate that, so that that sore can get better. If you don't eliminate the pressure off of it, nothing's going to help it.
That's the same as Granulax, right?
There is a difference, but I'm not sure about the Granulax, but I can tell you about the Proderm. Next, we have some oxygen apparatus. I do have a book, we can look it up in. This is normally what you'll see in a patient's home, a nasal cannula. And if you notice on the end of it, it has a curve to it. The curve should be pointing toward the patient, like this, and then around the ears. A lot of patients, when you go in and see them, they got the curve going the other way. It's digging into their nose, and it's not very comfortable, and it's going to make their nose sore. So all you gotta do is turn it around. The other thing is, after they've worn this for some time, it'll start to irritate their ears. Any of you that wear glasses, when you first start to wear glasses, it hurts until you get used to it. And then you don't even know it's there. Same with this. But if you do start to get some skin breakdown, redness, and it'll even open up on the ears from this hanging and pulling on the patient, you can put it on their nose. Like this. And then you can put it on top of their head and tighten it and then let it hang down their back so that there's no pressure at all on top of the ears. It works well when they're sitting in the chair, when they're sitting in the bed. You just tighten it right on top of the crown of the head. The other thing I wanted to show you was the humidification machine. There's a little rubber tube that comes off of the machine and it attaches to this. And then there's some threads. You have to make sure that when you put this container on, that it's tight. If not, the air will leak out of there. And then the patient's not going to get the oxygen because it's coming out of the leak. That's the first thing. Second thing, this top, this spins. This is also threaded. When you go to put it on, it has to be threaded correctly. It can't be offset. And it has to be tight, snug, secure. How will you know that it's working? Well, you put the distilled water in. You're not allowed to put just regular sink tap water in. It has to be distilled water that doesn't have the chemicals in it. There's a minimum line and a maximum line. I like to put it right about just above the minimum line, and I put a line there so you can see it. If you put too much in, it's going to force water up through the nasal cannula. It's just going to shoot into the patient's nose. You don't want that. So if you keep it just above the minimum line, that's going to prevent that from happening. There'll still be a little bit of condensation in there, but that's okay. They do make what's called a trap that will connect from here to here, and all it is about an 8-inch piece of tubing that's larger so that when the water goes through the small one, it goes into the large and it drops to the bottom, and then the air keeps going through the top. But distilled water only in here. It has to be rinsed and changed, the water, every day, because there's no preservatives, there's no alcohol or anything like that in it to kill bacteria, so bacteria will grow in this water. So every day you have to change it, and you want to put some in there, swish it around, dump it out to rinse out the old water. If you don't have distilled water, you can take sink water from the tap, put it on the stove, boil it for 10 minutes, let it sit and cool, and then you can put it in here. That's the only way you can use tap water. The next thing here is a nebulizer machine. Oh, let me back up to the oxygen first. Most of the time there's a concentrator. It's a machine that plugs into the wall. There's a real easy on-off switch, and then there's a ball that you adjust with a knob. You want to read the middle of the ball. If it says 2 liters, then you want the middle of the ball to be on the line that has a 2, not the top or the bottom of the ball. That's really important because you could be not giving them enough oxygen or giving them too much if the ball's not in the right place. That, and the other thing I wanted to mention was the humidification. If it's 2 or less in the oxygen, you don't have to have the humidification on it. But anything over 2, you should have it humidified. If a person's ordered 2.5 liters a minute or 3 liters a minute, I've seen it as high as even 4 liters a minute at home. You want it humidified because it'll dry the nose out, it'll crack, and it'll bleed. Because it's dry oxygen that they're getting, it's not humidified. So the key there is 2. If it's 2 or below, you produce enough secretions in your nose and passageways that you don't need it humidified. If it's higher than 2, you're going to need humidification on it. The next one here, some of you may be familiar with it. It's a nebulizer. There's a couple different types of tops on them. This one here is just a single mouthpiece, but they have the one that has the mouthpiece, and then they have a tube that comes out the end. All that does is help the medicine retain in one place longer, so that when you breathe it in, you're breathing more of the medicine down into your lungs. You connect this up to the machine. There's a simple on-off button. You push it. The medication, you untwist the cap. The medicine goes in here. Now, there is a small piece in here. This is the actual piece that causes the mist to occur. If you would put the medicine in there and didn't put this in, and put this on, all it would do is sit in there and bubble. It wouldn't mist into the air. So make sure that you have this piece and that you don't lose it. You put the medicine down in along the side, put this back on, turn the machine on. The patient simply sits there and breathes it in and out. It lasts about 10 minutes. When the mist stops, all you do is turn the machine off. You can use this all day, and then at night, you take it, you get your soapy water, and then you get your rinse water, and then you just set it on some paper towels and let it dry. Again, this has to be cleaned every night. If not, bacteria will grow in it. And then when you go to give this to your patient the next day, and they're breathing it in, they're breathing that bacteria down into their lungs. They're going to get bronchitis or pneumonia or something like that. Don't want that. Hot water bottle. Or cold water bottle, like an ice pack. The important thing that you need to know is 20 minutes. That's the most important thing I can tell you. Make sure you wrap it in a towel. You either put hot water in it or you put the ice water in it, whatever's ordered for the patient. But you're not to leave it on the skin longer than 20 minutes. And you never apply it directly to the skin, because you can actually cause tissue damage. You could either burn someone or you could cause them to get frostbite. 20 minutes is the longest period of time that you can leave it on. You can put it on every hour, but no longer than 20 minutes. And it does real good in helping pain and swelling, especially right after an immediate injury, the ice part of it. And then after like the first 48, 72 hours, then they'll switch them over to the heat. Okay. Foley catheter. Syringe here. Some of your patients will have, we call this their purse, because they hook it on and they carry it along with them. The Foley catheter draining their bladder. And if you notice at the end, there's a couple little holes. That's where the urine goes in and follows the tube down into the bag itself. Right here, you can see the different color in the tube. It's dark. If I were to put a syringe on the end of this, which I can't find my syringe, and push it, that would balloon. It would get about an inch, completely in diameter. And once the nurse puts this in the patient, they put the air in that balloon, it fills up, and then when they try to pull back on it, that's what actually keeps the catheter up inside someone. Someone's urethra can get loose over, a 90-year-old lady, her urethra can get a little loose, but they'll have a balloon on the end of it, and it can come out. It can just come right out. And that's happened. What you don't want to do is you don't want to snag this on anything, especially if you're turning someone in bed or transferring them from the bed to the chair or to a wheelchair. You want to make sure that this is, and what I like to do is I like to go ahead and just hook it right on my belt clip. And then you got your knees and their knees and you're holding them and you're moving them. That way it's not getting pulled on. Or if they have pants on, you can hook it on their pants. When you're putting their pants on and off with this, you want to take the bag and put it through the pants and then put the leg through. That way it comes down their leg, and then you can hang it on something down lower. It works by gravity. So when you lift it up in the air like this, whatever's in that tube is going back into the patient. So you want to be careful of that because bacteria does grow in this tube after a certain period of time. You want it to flow this direction toward the bag. So always keep the bag lower than the patient. But you also want to keep the bag off of the floor. So if a person's sitting up in a wheelchair, a lot of times they'll take it around and they'll hook it on the wheelchair. That way it's not just laying on the floor. The floor is dirty. It's considered a dirty place, a lot of bacteria. And believe it or not, the bacteria can get in this tube and it can actually migrate, can crawl all the way up through this tube and into a patient's bladder. So it's very important. Normally the nurse changes this part every 1 month, and the longest would be 2 months, the catheter itself. The bag here, it can be changed also once a month. It'll get real funky looking. If you have a lot of what they call white cloudy stuff in there, it's called sediment, that tells us that bacteria is growing in there, and the patient could get a urinary tract infection. If you notice that, if you notice any bleeding in it, any blood, it would be like a tea-colored, or it could be darker in color. That's something that you would bring to the office's attention. They may need to check it out. If you're going to be switching this over to a leg bag, you would put your gloves on. You would get an alcohol pad. You would clean the area between the clear and the dark plastic, latex. Then you would go ahead and pull it apart, disconnect it. And the new one, you would just simply reconnect and push it forward. That way it'll stay. A lot of patients use these, they're called leg bags, during the day, and then when they go to bed at night, they'll switch over to this bag. It's a nighttime drainage bag. This way they can get up and walk around, and they're not lugging that big thing there with them. So it's in their bladder. Then they have 2 straps on them. Simply goes around the leg, and then there's a little button with a slot that you attach. Important thing to remember is today you put it on the left leg. Tomorrow you put it on the right leg. You don't keep putting it on the same leg because, again, circulation, and this band is tight on the skin. You want to be able to get a finger or 2 underneath of it so it's not too tight. You don't want it to be filled up 100% so that it's pulling. You want to get it about 1/3 of the way to halfway full and then empty it. That would be less weight pulling on that skin on the patient's leg. And it's real easy to empty. Again, you put your gloves on. You either have a bucket that they use all the time to empty it, or if the patient can go over beside the commode, you can hang this right over the commode. All you do is spin it to the left, which would be counterclockwise, and it's open. Everything that's in it will drain out. When it's done, you want to spin it to the right, and that seals it. It's real simple. This one here to empty is a little bit different. This is called the housing. You squeeze the 2 plastic tabs and pull it out of the housing. And then you put this over your container or commode, and when you flip this switch forward, that releases the pressure on the tubing. I got called out to a patient's house one time because when they flipped this, nothing happened. They couldn't, it wouldn't drain. Well, here, this latex, it kind of stuck together against itself. So when I went out there, I had to drive 45 minutes to get to the patient's house, go in, I look at it, I flipped it open. All I had to do was roll the latex like this. And then the urine started flowing. I said, okay, I'm done. See you later. Drove all that way for like 2 minutes. So, if it's a brand new bag, that latex can stick together. That's what I wanted you to understand. But once you drain it, there will be some drips there. You can use some toilet paper to clean it off, or you can just shake it over the commode or bucket, And then you take this and you want to slide it back up in the housing. That keeps it off the floor and helps keep the bacteria from getting in it. Okay. One of the things that you will probably come across is a patient that's diabetic in the home and they're taking their own insulin. You have to know how it's done to make sure that they're doing it the right way. First thing the patient should do is grab their supplies. Their insulin, alcohol pad, and a syringe. The patient should wash their hands first, take the alcohol pad off, clean the bottle, and it's important to let the alcohol dry. When you put it on, alcohol is wet, and you hurry up and go ahead and stick a needle in, there's still bacteria in it. Alcohol kills bacteria as it's drying. So if you don't let it dry all the way, you didn't kill any bacteria. So now that it's dry, the patient is supposed to get 10 units of insulin. The patient will pull back to the number 10, and I'll pass this around so everyone can see. And they will put 10 units of air in because they're taking 10 units of fluid out. That way you don't create what's called a negative pressure inside the bottle. There's a little small circle, I'll pass this around too, in the top of the bottle. They're going to inject the air in, leaving the needle inside. They turn it upside down, and they pull back to 10. And I'll pass this around and let you just look at it. Okay, the next thing you need to know is site location. The patient's already drawn this up, but where are they going to get it at? Okay, there's a couple places.
Belly.
Yeah. Thigh, abdomen. If you take one hand, let me show you on your own. If you take one hand and put the pinky at the elbow and the other pinky at the apex of the shoulder, that's where it drops down. Okay? And then you take an imaginary line right down the center of the arm. From there, back. That's the only place that they can give it in the arm. Both arms. Okay? The line would be right here. From here back, from right there at the bottom of my shirt to right here. That's where the injection should be given in both arms. If you go below that, you could hit a ligament, you could hit a bone. You go above it, you could hit the joint. If you go in front of that, there are blood vessels and nerves that you want to stay away from. That's the safe place to give it. The thigh. You do the same thing with the thigh. If I bend my knee and put one hand at the bottom and one hand right up here where the hip creases, the imaginary line goes right down the middle. From here out is where it's given. Okay. Okay, I had to draw a picture of the patient's belly button. That's the dark black circle in the middle. Okay? Some are bigger, some are smaller, but that's irrelevant. From where the belly button stops, you go 1 inch and you make an imaginary circle. Okay? That's how far away you have to stay from the belly button itself. And then from that line to this other line here, the outer line, the outer circle, it should be 2 inches or it's 3 inches from the belly button. So from this line, this inner circle to the next circle, there's 2 inches and all the way around. Now you look at this as a clock. You have 12 up here. You have 6 down here. 3 and 9. Okay? Today you give it at 12 o'clock. Tomorrow you give it at 1 o'clock. Next day 2 o'clock. Next day 3 o'clock. That way you're rotating the injection site. That's really important. Because if you keep giving it in the same place, say 12 o'clock, every time, scar tissue is going to build up there. And then the medicine's not going to get absorbed into the skin like it should. Maybe only 70% of the medicine will get absorbed instead of 100. So if they rotate it every day around the circle, they'll prevent the scar tissue from building up real fast, and they'll get effective amounts of medication. Enemas. The patient can either be sitting on the bedside commode, the toilet, or they can be lying in bed. And if they're going to be lying in bed, they should be lying on their left side. Because if you look at the ascending, transverse, and descending colon, it goes up on the right, across, down on the left, and then out. So if you're going to put them on their right side, you're going to put this fluid in, it's going to go this way and then this way. And gravity helps. So it's going to be too hard for the fluid to go back uphill and to come out. So you always put them on their left side. Only expose the areas that you need to expose. Make sure you have your gloves on. Don't put this in the microwave. You could burn someone. I know people that have done that. You take the cap off. It's already pre-lubricated. You don't have to worry about putting any KY jelly on it. But you want to squeeze the air out first. You don't want to give them the air. Once you get the air out, you want to insert it. And you want to insert it all the way, because in the rectum there's two muscles. There's the outer sphincter muscle, and then there's an inner sphincter muscle. You have to get this past both of those muscles. And then you want a nice, strong, firm, even pressure when you squeeze. And sometimes you might even need to use two hands to squeeze. And you kind of roll it up a little bit like the toothpaste when you get to the end. Give them as much as you can give them. They should hold it in for at least 20 minutes. And what it's going to do is